Hello, everybody, and welcome to the Health Occupations and Long-Term Care Subcommittee, our second meeting, I think our second meeting of the session. I'm losing track already, though. We have a very long agenda today. We have 10 bills. We are not going to get through all of them. We're currently letting in stakeholders, and then they're going to be muted and going to be able to speak on their bill as their bill comes up. So at the top of the meeting, I just want to make sure everybody has a sense of the order that we're going to go in, because it is not the agenda order. As is the sort of tradition in this subcommittee, we try to get out the bills that we think don't need as much discussion earlier in the agenda so that it helps us with our workflow. So I'm going to reorder the agenda for you guys right now. The first bill we're going to come back to is the bill we discussed last week, the dispensing permits bill, House Bill 260. Then we will take up the nurse anesthetists bill, House Bill 55, followed by the acupuncture bill, House Bill 180. Then we will do the dialysis bill 218. I should mention that almost all of these bills have some type of amendment on them. So 218 is after that. The Alzheimer's Council 166 will be next, followed by 220, which is the massage bill. If we have time, we will then, I think all of those we can probably vote out today. With the exception of the dispensing permits bill. We'll get to that. After that, we have 276, which is clinical nurse specialists, 173, which is social work, 219, which is dental hygienists, and 66, which is midwives. We are not expecting to vote on those bills today. I am hoping that we have time to start conversations on some of those. With that, we will start returning to the conversation very briefly on House Bill 260, which is the dispensing permits bill. I'm going to go with that was a Lisa bill, but I can't remember.
Nope, that was mine.
Just kidding. I'm sorry, guys. I forgot to remember which staff person has been working very hard on which of these bills. Lindsay, can you remind us where we're at with this bill? And then I'll update the committee members on where we could be going.
Sure. This bill transfers oversight of the inspection of the offices of physicians who prepare and dispense a prescription drug or device from the Office of Controlled Substances Administration to the State Board of Physicians. And the bill also moves related provisions from the Maryland Pharmacy Act to the Maryland Medical Practice Act, There were amendments that were offered and not voted on last week that transfer positions, funding, and records relating to inspecting the offices of physicians from OCSA to the Board of Physicians. And otherwise, the bill was held last week.
Great. So I think all the members of the committee received some communications from Pat O'Connor from the AG's office. Is Pat on the call right now? Are you here, Pat? No Pat O'Connor with us today? Curious. Okay, let's wait and see if we hear from Pat. I will update the committee, but might as well use our time efficiently and move on to nurse anesthetists, unless I'm looking at Matt and Dana. Do you guys want to talk now, or do you want to wait until we have Pat? Because I think that I'll tell you guys what my opinion is. We need to get everybody in the room talking on the same page. I know I spoke with Senator Lamb this morning. I spoke with Delegate Carr this morning. They both are interested in having a meeting with Pat and the Board of Physicians and MedChi to get to the bottom of the miscommunications about this bill. It's very, very important that that meeting happen. So we can wait until Pat joins us, if she joins us, or Matt and Dana could sort of address some of the information in the letter we all received. Which you guys prefer, Matt, Dana?
I am happy to defer to your judgment on that.
Let's wait a few minutes and see if she shows up. I'm sure you guys have other issues in our subcommittee today, so I don't want to waste your time, but let's move on to nurse anesthetists, House Bill 55. Lindsay?
This bill authorizes a nurse anesthetist to prescribe, order, and administer drugs, including specified controlled dangerous substances. The bill designates a licensed nurse anesthetist as an authorized prescriber under the Maryland Pharmacy Act. A nurse anesthetist may prescribe drugs only in an amount that does not exceed a 10-day supply, only for an individual with whom the nurse anesthetist has at the time of prescription established a client or patient record, only in connection with the delivery of anesthesia services, and as introduced without obtaining approval from a practitioner with whom the nurse anesthetist collaborates. The bill also, as introduced, authorizes a nurse anesthetist to collaborate with a podiatrist regarding the administration of anesthesia. There are amendments circulated on this bill that remove language in the bill that would have authorized the nurse anesthetist to prescribe drugs without obtaining approval from a practitioner with whom the nurse anesthetist collaborates, and also removes the language authorizing a nurse anesthetist to collaborate with a podiatrist regarding the administration of anesthesia.
Okay, Delegate Cullison, do you want to update us? We need to adopt these amendments. Anything else we need to know?
Thank you, Madam Chair. I think with these amendments, we have overcome all of the opposition to the bill. I would move the amendments.
Second.
Second, any discussion about the amendments or any questions on the amendments from the committee? All in favor of the amendments, say aye.
Aye.
Anyone who's opposed, go ahead and raise your hand and we'll note that. No one's opposed. On the bill as amended, anyone want to move the bill? Okay.
Second.
Moved and second. Any discussion on the bill or any questions for the stakeholders here on the bill? It seems like everybody is on board with this, with the amendments, right, Delegate Cullison?
Yes, Miss Madam Chair.
Excellent. So it's been moved and seconded. All in favor, say aye. Aye.
Aye.
Anyone opposed? Nobody is opposed. Passes unanimously. Well done, Delegate Cullison. Oh, another one from Delegate Cullison, 188 acupuncture. Lindsay? Lisa.
House Bill 188 alters one of the education and training pathways to qualify for a license to practice acupuncture in Maryland. Beginning on or after May 31st, 2026, an applicant will qualify for licensure if the applicant is both certified by the National Certification Commission for Acupuncture and Oriental Medicine and passed an examination determined to be equivalent to the examination given by the Certification Commission, rather than only needed to meet one of the qualifications. So right now it's an or, we're changing an or to an and, but we're giving everybody a couple of years before that change is made. There is an amendment that corrects a typo. Bless you.
Okay, Delegate Cullison.
Thank you, Madam Chair. There was no opposition to this bill. I would move the amendment.
Second.
It's seconded. All in favor? We're good, typo. All in favor, say aye.
Aye.
Anyone opposed? Nobody's opposed. Okay, on the bill as amended.
Move the bill as amended.
Second.
Moved and seconded. Any further discussion on the bill as amended? Makes sense to me too. All in favor, say aye.
Aye.
Anyone opposed? Nobody's opposed. Well done. House Bill 188 passes unanimously. So let's go back to 260. I hear that Pat O'Connor has joined us. Pat, are you here?
I am.
Excellent. So on House Bill 260, we were talking about sort of where we left off last week, and then the members all received a letter from you. So it would be great if you could, we're trying to come up with a plan for moving forward with this bill and figuring out how to get the appropriate communications happening. I think there's a lot of disagreement just on the facts of what the bill does and the implications of the bill that we need to get to the bottom of before we take up more time from the subcommittee. So I would like for you to give us just 4 sentences on your concerns. And then we're going to have the Board of Physicians and MedChi give us 4 sentences. So we'll start with that. And then I'm going to direct you guys to meet before the next subcommittee with the sponsors of the bill. So let's hear your 4 sentences first.
As explained in extensive email exchanges with Matt and with Stacy before we filed our original letter.
Hey, Tyler.
With HGO. Yes. The bottom line concern is that the change will deprive prosecutors, including prosecutors in this office, from of the admissible evidence that is needed to obtain criminal convictions of physicians who illegally prescribe opioids. And that is because the Board of Physicians, under Health Occupations 14410, has obtained absolute protection of any record of any investigation or disciplinary proceeding the board undertakes. Thus, Board of Physician inspections will never produce admissible evidence that is needed to obtain the criminal convictions. In contrast, OXA, the Office of Controlled Substances Administration, has no such protection. OXA routinely shares the results of its inspections and its investigations with law enforcement and prosecutors throughout the state.
Okay, thank you very much for explaining that to us. Matt, do you want to give us 4 sentences?
Yes, thank you. First, I just want to emphasize once again that the purpose of HB 260 is to increase oversight of these dispensing physicians, not to weaken it. Regarding the claims of inadmissibility of evidence in Health HOC 14410, 14410C clearly states that any medical or hospital record or other exhibit that is subpoenaed and would otherwise be admissible would still be admissible and would not be prevented from being produced in the proceedings of other investigatory bodies. And in fact, we have frequently had subpoena requests from the Office of the Attorney General that have resulted in documents being produced. And then third, there are just a number of other misrepresentations in the letter, such as the claim that the bill would remove training requirements, which is flat out incorrect. And finally, the bill also does not include a fee reduction. And I believe our fiscal note makes it very clear that any reassessment of inspection costs would likely not occur until fiscal year 2025.
Thank you. Dana, anything for you to add?
Yes, thank you very much. Just wanted to build on what Matt just said. First of all, the statement that the bill eliminates training requirements is false, because if you look at page 9, lines 26 through 28, it states that the physician must comply with continuing ed requirements by regulations, which have not changed. The statement that the dispensing physicians avoid the oversight of the PDMP is blatantly false, because as you know, Title 21, Subtitle 2A requires dispensers, including healthcare practitioners, within 24 hours of dispensing to report to the PDMP. So I'm not even sure what that is saying. And then also, last 2 sentences, just reconfirming OCSA, we are not changing any of their requirements or obligations under the law. They still, under Title V, have the authority over any dispensing physicians with a CDS permit, and that includes inspections of the offices. And my last statement is really just to point out the fact that in the AG's written opposition, they allude to the integrity of those who serve on the board and of the chair. And I have to just say, I find that very shocking and inappropriate to make that type of statement. And I've been down here for 24 years and I didn't think much shocked me. But when I read that, I was very taken aback. So I appreciate the opportunity.
Thank you. So with that, I really appreciate Delegate Carr and Senator Lamb being willing to take on facilitating a meeting between these stakeholders to get to the bottom of
Don't worry about those today.
the truth, the answers between the different perspectives on what 14410C and all these other 2A. I think that's Sue. Maybe we need a mute. So Delegate Carr and Senator Lamb are going to be our representatives in the legislature to determine what of these concerns are legitimate and we need to address in the subcommittee next week. If there are legitimate concerns related to OCSA, obviously this committee is committed to that. We want to address that. If it's a misunderstanding, if it's already covered in the law, if it's not going to create the problems that the AG's office is concerned about, we will know. So thank you, Delegate Carr, for having a meeting before next Wednesday. This subcommittee may be meeting on Wednesday instead of Thursday next week. So that means this meeting with stakeholders on this bill has to happen before Wednesday. Can you do that, Delegate Carr, for us? Thank you. And Pat and Matt and Dana, can you make yourselves available for that, please?
Absolutely. Thank you.
Absolutely.
Excellent. Thank you very much. Okay, so with that, we will come back to this bill next week. And the next bill on our agenda is, oh good, me, 218 dialysis. I'm gonna say that's a Lindsay bill.
Is bill repeals the requirement that a dialysis technician be a certified nursing assistant and instead establishes a separate certification for a certified dialysis technician under the State Board of Nursing. The board must adopt regulations establishing qualifications for dialysis technicians, maintain a list of all dialysis technicians, set applicable fees, and initiate specified disciplinary action. The board must evaluate dialysis technicians who request participation in the program and report to the board the name and certificate number of any dialysis technician expelled from the program for failure to comply with conditions of the program. And the bill expands the membership of the Certified Nursing Assistant Advisory Committee to include one certified dialysis technician and one additional administrator from a licensed healthcare facility. There are amendments that were circulated on this bill that changes require an individual to be certified by the board to practice as a certified nursing assistant and as a dialysis technician before the person may practice as a dialysis technician in any state-owned hospital or state-owned facility, and removes obsolete language relating to criminal history records checks for medication technicians, and alters language relating to training requirements for certificate renewal.
And it is my understanding that with the amendments on this bill, everyone is okay. Do we have any stakeholders here? Dana, do you want to talk on the bill?
Sure. Thank you very much. And with the amendments that were put forth by the Board of Nursing and others, we reviewed them, we accept them, and we appreciate everybody coming to the table to put forth this bill. Thank you.
Excellent. Anyone from the Board of Nursing here? I'm not sure. There's so many people in this week. It's hard for me. But I do know that we appreciate their amendments, and I'm going to go ahead and move the amendments. Anyone want to second them?
Second.
Second. Okay, moved and seconded. Any discussion or questions about the amendments? Okay, all in favor say aye. Aye. Anyone who's opposed, raise your hand. Nobody's opposed.
Move the
Okay.
bill as an amendment.
Thank you. Moved and seconded by Delegate Krebs. Any further discussion on the bill? Okay, all in favor say aye.
Aye.
Anyone who's opposed, go ahead and raise your hand in the chat. Perfect. Go team. Well done. 218 passes unanimously. Let's move on to Delegate Sample Hughes's bill. And again, I'm sorry that there's so many people in this week. I cannot see everybody. So I don't know if Delegate Sample Hughes is with us.
Yes.
But we can. Oh, you are. Excellent. Wonderful. And this, I believe, is a Lisa bill. Lisa? Yes.
This bill establishes a Director of Dementia Services coordination position in the Maryland Department of Health to coordinate and facilitate communication relating to dementia services in the state. Beginning in fiscal year 2023, the governor must include an appropriation in the annual budget to fund the director position and the council by September 1st, 2022, and each September 1st, every 5 years thereafter, the council must issue and publish an update to the state plan on Alzheimer's disease and related disorders by September 1st, 2023, and each September 1st, every 5 years thereafter. The director must report to the governor and specify committees of the General Assembly on the activities and recommendations of the director. There are several amendments to the bill. The amendments alter the name of the council and title of the director. They change the staffing requirement to the director and the Department of Aging. They clarify that the director's duties include coordinating the department's approach to addressing Alzheimer's and other forms of brain health, including public awareness, prevention, and early detection and diagnosis, developing and monitoring implementation milestones and measurable outcomes for the state plan, coordinating public and private stakeholder partnerships, and applying for grants to enable the implementation of the state plan and its goals. And finally, the amendments specify the appropriation amounts for the director's salary.
Excellent. And these amendments, Lisa, we expect the Senate is going to be putting on identical or nearly identical amendments. Do we know?
We're close. I don't think they're going, at the moment, at least the last I heard, they weren't identical, but they're close.
Okay.
Yes.
So let's hear from the sponsor. Go ahead.
Sure. So, Madam Chair, so those amendments have been sent to the Finance Committee. And so then we'll move forward with that. So they do have the identical amendments at this time. And those changes and requests that was brought on from the council itself. And so those are the changes, and that's where we are.
Okay. Anybody want to move the amendments and then we can discuss the amendments?
Move the amendment.
Second.
Seconded. Any questions on the amendments for the sponsor or the stakeholders? Oh, Delegate Collison.
Thank you,
Followed
Madam
by Delegate
Chair.
Bagnall.
Thank you, Madam Chair. Just for the sponsor, are you comfortable with putting it under the Department of Aging? And what kind of coordination will there be between the Department of Aging and the Department of Health?
And just Delegate Sample Hughes, I'm sorry, I forgot to, I know you have some stakeholders here. So if you want to punt to Eric or someone else, by all means.
Sure. Let me go to Eric on that question.
Thank you, Delegate Sample Hughes, for the opportunity, and thank you so much for your leadership on this bill. The question of which department this bill would fall under has been something that is really important to consider. And the bill was developed to pair in line with recommendation 1A of the State Alzheimer's Council, which suggests that this should be under the health department. And the primary motivation for that is that the person we believe is best positioned to succeed within the health department, where they can touch so many of the different issues that this role best works on. Not on the most basic level, dementia is a chronic disease. Dementia, just like some of the other chronic diseases that fall under the health department. So with that in mind, I think that was a core reason why we did it, because it touches on chronic diseases, because it touches on Medicaid, because it touches on the healthcare workforce, because it touches on so many different issues. Now, there remain other issues that the Department of Aging works on, and our goal and our hope is that this person can implement the cross-cutting vision that the state Alzheimer's plan lays out. And we, again, just believe they're best positioned to do so at the health department and have that umbrella of different issues that they can connect with and effectively leverage to aid 110,000 Marylanders with Alzheimer's and their over 300,000 caregivers.
And the amendments do what you're looking for.
Yes, the chair of the council is here. I didn't see her a while ago. She could have been the one to respond to that, Ms. Samus. So at this juncture, where the amendments speak to the expansion of the duties specifically, if you recall in the bill hearing, I said that I wanted to clarify the duties of the position more streamlined to know what they're going to be responsible for doing, and then also making sure there's an appropriation for this on an annual basis.
Okay.
So before we go to Delegate Bagnall's question, let's hear from Ms. Samus since she's here. Is that okay, Delegate Collison? Did you have a follow-up? Okay, let's hear from Ms. Samus. Go ahead.
Yeah, thank you so much. So I just wanted to clarify one thing. So these recommendations that were in part reflected here were coming from me as a subject matter expert, and I was not speaking on behalf of the council or as on behalf of my employer, which is Johns Hopkins University. So I'm a health services researcher who I also happen to be the chair of the council, but I want to make clear that these came from me as an individual, and they reflect my work in this area over the past 20 years or so.
Okay, Delegate Bagnall, did you have a question? Or Delegate Collison, were you done or did you have follow-ups? I'm sorry, I didn't mean to cut you off.
Well, thank you, Madam Chair. If the sponsor feels like the amendments do what they need to do, then I'm comfortable with that.
Delegate Bagnall.
Thank you, Madam Chair. And I just had a similar question for the sponsor regarding the term brain health. If that was still keeping it within the confines of the intention of the bill, or if that broadens it into touching other areas of behavioral health, without making sure that we're refining it for a focus on dementia.
Thank you for the question. So that was certainly brought up as a concern for language purposes. And the final decision was on the brain health of use and of that, and still keeping in line that is still related to dementia services.
Thank you. Thank you, Madam Chair.
Delegate Krebs.
Again, I'm trying to do the same, make sure that our intention on page 4, line 7, it talks about the director. And so when they talk about the director, that's the director of the Alzheimer appointed member. And then it says with the assistance of Department of Aging. So why is the Department of Aging in it here and not the Department of Health? On page 4, line 7.
That's who's helping with the staffing. The director is part of the Department of Health. So that.
Okay, so
that's what
it's going to be on. This is going to fall under the Department of Health, but Department of Aging is going to help with the staffing.
That's the way the bill reads. Yes.
No, I mean, I guess we're talking about moving it back to the Department of Health. Should we move it all back to the Department of Health? I mean, I don't know what the intention is of the bill sponsor, but I just want to make sure we're having it aligned because we talked about moving it back.
Yeah, the intention is to have it underneath the Department of Health. That's where the Alzheimer's Council is housed under. And so to keep that in line and streamline it is the intention of the bill. But
Okay,
certainly, as we know, Department of Aging needs to be a part of this, partnership, and the fact that Department of Aging has additional information, but it needs to still be housed under Department of Health.
I got you, but online.
Delegate Krebs, can you give us the reference again? What
Page 4, line 7 and 8. It just
says with the assistance from the Department of Aging. So the department
shall provide the staff. Okay, we just want to make sure the staffing is where you intend it to be in the Department of Aging versus Department of Health.
It's in both. It's
both. Okay. Just want to make sure that we've got clear what your intentions are. I agree with your changes.
Delegate Bandari.
My question is answered. Thank you.
Perfect. Ms. Samus, did you have something else you wanted to add? Your hand's still up. I don't know if that's from before.
Yeah, I just didn't know if you wanted further clarification on the justification for the brain health in this.
That would be helpful.
Yes. So it reflects a few things. First, it directly aligns with Goal 1 in the forthcoming plan that's going to be coming out of the council for 2022 to 2026 strategic planning for ADRD. Also, it reflects the current state of our scientific understanding about known risk factors for dementia. So it places an emphasis on risk reduction and prevention. And then third, it also aligns with the brand new National Alzheimer's Planning Act strategic plan for the nation, which just added at the end of December, Goal 6 that directly refers to risk reduction and prevention. So it aligns with national initiatives as well.
Thank you for that. So we have moved and seconded these amendments and we've discussed them. I think we have all of our questions answered on the amendments. So I'm going to say, if you're in favor of the amendments, say aye. Aye. Anyone opposed to the amendments? Looks like we have unanimous support for the amendments. On the bill as amended.
Move the bill.
Delegate Collison moves. Delegate Bagnell seconds. Okay. Everyone seconds. Any further discussion on the bill or questions on the bill as amended from the committee? Well done. All in favor of the bill, say aye. Aye. Anybody who's opposed, raise your hand in the chat. Unanimous passage. Well done, Delegate Sample Hughes. House Bill 220. We're making good time, guys. I know it seems like we're not, but we are. House Bill 220, I think.
Is mine.
I'm going to go with Lindsay. Yes, thank you.
This bill phases out the registered massage practitioner credential under the State Board of Massage Therapy Examiners. The bill prohibits the board from issuing an initial registration to practice as a registered massage practitioner on or after October 1st, 2023, and then beginning November 1st, 2026, an individual must be licensed by the board to practice massage therapy in the state. The bill also alters registration and licensure qualifications and subjects an individual who practices massage therapy without a license or registration to a civil fine up to $50,000. The bill repeals the requirement that the board adopt an official seal and requires the board to maintain an electronic roster of individuals licensed or registered by the board. I circulated amendments on this bill that require a licensed applicant to have graduated from an institution of post-secondary education rather than higher education, retains the requirement that the institution be approved by MHEC, requires the curriculum to be both endorsed and accredited, and allows the accreditation to be only by an institutional accreditation agency recognized by the U.S. Department of Education.
Excellent. So if it's okay with the committee, I'm going to suggest we adopt the amendment from MHEC and then discuss the bill as amended with that amendment. Is that okay with folks? I'm going to move the amendments. Great, moved and seconded. Any questions on just the amendments for MHEC? There's just language changes. All in favor say aye. Aye. Anyone who's opposed? Delegate Morgan, are you opposed to the amendment? No, you have a question on the bill. Excellent. So we do have stakeholders here on the bill. I see Amelia Mitchell, Caitlin Thompson, I think Sharon Oliver is here. Anyway, whoever is here on the bill, Delegate Morgan has a question. Let's go to your question and then we'll see if we have stakeholders who can answer. If not, I'll answer. Delegate Morgan.
Just a couple of questions. Thank you, Madam Chair. First on the civil fine, $50,000. Is that comparable to other licensures?
There's 11, sorry, if I could just jump in.
No, please, Caitlin.
Yeah, there are 11 other boards that have that exact same civil penalty under the Department of Health.
Okay.
For example, I think it's like physical therapists, occupational therapists, so similar licensure levels.
Okay, thank you.
Great clarification. Any more questions, Delegate Morgan?
Well, I did have a question on the educational requirement. It says you have to have and did that change in the amendment that you have to have it says higher, well, I guess that's an associate's degree, 60-hour course or 60 out. Like, what is the education?
Let's do a little explaining because it's an important change that I think everybody wants to make. I don't know if it's Caitlin or Amelia or Maura is best to explain the reasons behind this.
I'll take it. I'm Amelia Mitchell with the American Massage Therapy Association Maryland chapter. What we're doing is removing a lower tier of registered massage practitioners here. There has been this two-tier system that created very unequal situations for people with exactly the same massage training for the last 20 years, and it hasn't worked. The public doesn't understand it. Employers don't understand it. And so what we're doing is moving everybody into a single tier of licensed massage therapists. We're changing the education requirement. And most importantly, we're removing the requirement for a college education because we are literally the only state in the country that requires an associate's degree to be a licensed massage therapist. And interestingly, that college education has a bit more science in it, but the massage training that everybody in this state is getting is identical. So we're simply changing it so everybody has the same training and can be a licensed massage therapist.
Okay, thank you. That answered my question. I appreciate it.
Excellent. No, I'm glad we were able to clear that up. Any more questions from the committee? I don't see any more hands up. I can't remember if the bill's it was amended, but the bill as amended needs to be moved.
Yeah, move the bill.
Delegate Krebs, did you have a question?
Just a quick question. How many people will this affect that are currently licensed, or will it affect anybody currently licensed?
Yeah, there's a transition plan. Go ahead, Amelia, do you want to answer?
Right now, there are 1,500 RMPs, and the board has to write regulations, but they have a good plan from our understanding. Those RMPs will be transitioned to LMT over the next 4 years, essentially, with different requirements. Basically, they're looking for everybody to basically meet the new educational requirement of 750 hours, and will provide a variety of ways for people to meet that are not onerous and do not require people to go back to school or spend money. So the current people, even after the transition, will not need to do this? They have 4 years to do it. The current people over the next 4 years will be transitioned and become licensed massage therapists. And in the new people will, after 2023, there will be no more RMPs created. Everybody will have to meet the new LMT standards.
All right, so let me make sure I understand. So the the current people that are being transitioned will have 4 years to meet the requirements?
Yes.
And
the
how many-
require,
how many
I think it
people
would be good if
that?
Caitlin Thompson can probably answer this from the board because she's developing the regulations for the
Okay.
plan. Go ahead,
Okay.
Caitlin.
Who it would impact and what the impact is. Thank you.
Absolutely. So currently we have 1,500 RMPs in the state, just over. And by the time this would go into effect, without doing anything else, over half of them will automatically legacy because they will have had their license for 10 years. We have a few paths to transition into the new licensing. We're also accepting work experience as well as the already pre-required continuing education that people have to take. So we're working very hard to make sure that all of our RMPs will be able to get to that level, including work experience, without having to spend any extra money. And most of this, yeah, absolutely, yeah.
Thank you. It sounds like it was very thoughtfully done. Thank you.
I agree, Delegate Krebs. I'm very impressed with how this process has been handled by the stakeholders. I couldn't have asked for more. Delegate Bagnall, was your question answered? Excellent. So I don't remember if we've moved the bill. I think we have not. Anyone want to move it?
I
We
moved the
have.
bill.
Oh, Delegate Saab moved the bill. Was it seconded?
Second.
Moved and seconded. Okay, any further discussion? All in favor, say aye. Aye. Anybody want to be recorded as opposed? Go ahead and raise your hand. I see no hands up, so that is also unanimous. What do we want to do next? Let's talk about clinical nurse specialists, House Bill 276.
This bill authorizes a clinical nurse specialist to practice as a clinical nurse specialist for the purpose of prescribing drugs and durable medical equipment. The bill designates a clinical nurse specialist as an authorized prescriber under the Maryland Pharmacy Act. Practice as a clinical nurse specialist is governed by rules and regulations adopted by the Board of Nursing and that concern additional acts in the practice of registered nursing. The bill specifies that an advanced practice registered nurse with prescriptive authority working with a physician in the same office setting is not prohibited from prescribing specified drugs. There is an amendment circulated that alters the definition of practice as a clinical nurse specialist to remove language relating to ordering, performing, and interpreting diagnostic tests, and instead adds to the definition the ordering of diagnostic tests and use of the findings or results in the care of patients.
Okay, so I know we have some stakeholders here. I know I saw Lorraine, Diana, Shirley, DeVaris. Let's go to Delegate Cullison and maybe she can tell us who is here, who can answer questions on this bill and where we're at. Delegate Cullison?
I think we're very close, Madam Chair. And I think that the amendments that Lindsay just referred to address the issues that we are clear about in terms of, those who are still uncomfortable with the bill. So if I might, could I move those amendments?
Certainly, I will second them. Do we have questions just on the amendments so that we can get closer to where we need to be on this bill? I don't see any hands up on the amendments. All in favor of the amendments, say aye.
Aye.
Anybody who's opposed to the amendments, raise your hand in the chat.
And if I might follow up, then I guess I'm going to ask, because I want to, Shirley DeVaris, a question. Clinical nurse specialists have the same fundamental training as, I'm asking a question, I'm not stating, same fundamental training as all advanced practice registered nurses who already have all other categories of those advanced practice nurses already have prescription authority. Number one, is that true? Number two, in your experience, have there been any significant issues with that prescription authority?
Before you answer that question, Shirley, take time to think of your answer. I don't mean to mess with everybody's flow, but I'm just looking at the clock and it is 11:42. So I'm going to say we've got 4 bills left. We don't expect to vote on any of the bills, but we do want to start the conversation on them since the stakeholders have been here. So we'll talk about this bill for like 8 minutes and then we'll talk about the other bills for 8 minutes. So we'll just give you some time to make your case. Go ahead, Shirley.
In answer to Delegate Colson's first question, and thank you, Delegate Colson, for helping us with this bill. They absolutely are trained to do this, and they have comparable education to our nurse practitioner and our certified nurse midwives, who already have prescriptive authority. The second question was, problems?
Yeah.
None at all. And we did, Lorraine Diana can to address this better, but there was a research done, and there have been no problems in those states where clinical nurse specialists prescribe. In fact, there have been 0 cases that we could find as far as complaints about prescribing. So I don't think that's going to be a problem here either, because they're pretty devoted nurses, want to do a good job.
Thank you, Shirley. Good to see you.
You too.
We have a question from Delegate Saab.
Thank you, Madam Chairman. I think Shirley answered part of my question. I was just looking at the opposition letter from MedChi, and I just want to make sure that these amendments addresses their opposition regarding expanding the scope beyond what nurse practitioners do. So I just wanted to clarify, did the amendments address that?
Do you want me to answer that?
It's up to you. I think we have someone from MedChi here too, so we'll hear from both you
Okay.
or the sponsor, whoever.
That amendment was really meant to address the radiologist concern. They didn't want it to, the wording as it is in the bill, to imply that they could read MRIs and CAT scans, and that was not the intent. So that's why the amendment was done, to clarify that they will be using the interpretation of those diagnostics. They can still order them, but they're not to, they will not be interpreting things as complicated as MRIs or CAT scans.
Okay, yeah, I guess I'll wait to see what MedChi have
Well,
to say.
that's,
Thanks.
is it Steve who's here on this bill? Who's here on this bill from MedChi?
Yeah, it's Steve. I'm here, but my video was blocked a minute ago, so I'll just talk, I guess.
Sorry. I'll see if I can get it back on for you. Go ahead, keep talking, and I'll see if I can get your video on.
Okay, there.
Oh, there you are.
Yes, so to Delegate Saab's question, the amendment that was taken on the diagnostic images is something that I spoke to Mr. Pavaz about, and they addressed. So I appreciate that. So that is one issue resolved. But if you want me to go beyond that and just sort of tell you where we are on the bill, I can, or I'll come back.
No, this is a great time because we've only got 4.5 more minutes on this bill. So let's hear where you guys are now.
So very briefly, we continue to wrestle with this, and we have looked at the education and training, and it's interesting because we've been sent the same documents from individuals on both sides saying this supports their side of the equation. And we're trying to talk to some docs who have worked closely with clinical nurse specialists to get their feedback on it. The ones we've heard from don't believe that despite similar training, that they're exactly on par with nurse practitioners who are already able to prescribe. So we're trying to continue to get some information on that, and we'll be here with the subcommittee as you move along. But part of this is just my final comment. The statute on clinical nurse specialists was sparse until there were some regulations proposed in the fall. And we commented on those regulations, but the statute specific to clinical nurse specialists, there's very little. So we're kind of starting from scratch here, trying to figure out what have they in the real world been doing over these years, and to make sure that what's proposed here doesn't go well beyond the training and qualifications that's there, despite their similarities to nurse practitioners. So that's where we are.
Very helpful. Thank you. Is there anybody, I don't know if this is for Shirley or Lorraine, who wants to respond to that, the comments about sort of similar but not identical training?
I can respond to it. In particular, there are national standards that are set forth by the 2 certifying bodies for clinical nurse specialists to practice. And the scope of practice regulations that were put forth were based on those national standards to which clinical nurse specialists have to adhere. So there's well designated scopes of practice. They just weren't in COMAR yet, if that answers the question.
Brings us closer, I think. Delegate Collison, anything more we can do with this conversation this week? Anything else we want to address at this point?
I think we just need to regroup and see what we can work through, but I appreciate your time on this, Madam Chair.
And just, I guess I have a note from my file in the, from the hearing that Dr. Hill had a question, which I think is worth it for this committee to answer if we move forward with this bill. You know, why are you, I don't want to quote her, this is not an exact quote, but my note was, her point was, why are you saying you're as good as a nurse practitioner and not as good as a doctor? Because the doctor should be the standard. Anyway, I just know that however we can frame that question, you know, we need to make sure that we can answer, you know, as we move forward with this bill, something in that space. That's my hope, because we have to get it out to the full committee and we'll have to answer it at some point.
Thank you, Madam Chair.
Wonderful. So with that, let's come back to this bill next week and hopefully we'll have a little bit more clarity and members can do their own sort of digging over the week as well. Our friendly social work bill. Let's spend 8 minutes on that one. House Bill 173.
So this bill is identical to a bill we had last year that was a Senate bill, and we adopted some amendments and this passed unanimously out of the committee. The bill authorizes the State Board of Social Work Examiners to issue a temporary license to an applicant who, except for passing the required exam, has otherwise completed the appropriate education and experience required for a license to practice bachelor social work or master social work. The board may issue a temporary license if a required exam is unavailable to an applicant for a period of at least 7 days. A temporary license is valid until 90 days after the exam becomes readily available to the applicant. A temporary license authorizes the holder to practice bachelor social work or master social work in the state only under the supervision of a board-approved supervisor while the temporary license is effective.
Okay, so if everybody who was on the subcommittee last year remembers that we talked about this bill for multiple weeks last year. And then passed it unanimously. So I just want to remind the subcommittee, because the hearing certainly was unusual for a bill in that posture. I want to make sure that the committee has the opportunity to hear again. It sounds like, you know, the stakeholders have another bite at the apple because it didn't get through both chambers in time last year. Just reminding the committee that we have so many bills to deal with and we could take another 6 weeks on this conversation, which will make our lives very hard. So I would like to avoid that if possible. That being said, people are allowed to change their votes if they don't, you know, if just because you voted for it last year and if you learn new things about it or something, you change your position, you know, that's allowed. With that, I'm going to pass it to Delegate Bagnall, who can give us an update, and then we can hear from the stakeholders. Delegate Bagnall.
I'm going to speak briefly because I think what we have is simply a philosophical difference. So there are no amendments beyond the amendments that were offered last year that we adopted in the drafting of the bill. And I'm going to turn it over to the stakeholders because you know, I have tried to be careful in the framing of these conversations to not in any way malign the industry. Which we are discussing.
Excellent. And so is Mary Beth DiMartino here? Is that who you want to send it to, or Scott Tippin, or?
Yeah, I think we're both here, Madam Chair. Me and Mary Beth are both here.
Why don't you start, Scott? I knew we have a question for Delegate Krebs, but give us what you want to say, and then we'll hear from Delegate Krebs and Delegate Morgan. We're going to do 6 more minutes on this bill.
Okay.
Go ahead, Scott.
Perfect. And I think Delegate Bagnall is
Can't
perfectly.
get in again.
I think Delegate Bagnall is completely right that there's just a slight philosophical difference between NASW and the board. You know, over the past, couple, I guess it's been 2 years now, we've talked to the board multiple times, and we're definitely open to keep having those dialogues. But I think we think right now the bill is set up in a posture where it keeps the public perfectly safe. Several other professions in the state have temporary licensure. Several other states also have temporary licensure for social workers in other states. So we think it's, set up perfectly well.
Let's hear from Delegate Krebs.
Thank you. And I want to thank Scott and Mary Beth we had a long conversation about this last week, I guess. And we definitely have a problem that needs to be solved. And obviously last year we were in the middle of COVID and it was a little bit different, but I just have a real problem with how we're trying to solve the problem with temporary licenses. And we keep saying that other health occupations give temporary licenses. And I just happened to come across the nurses, and the nurses give temporary licenses, but they have to take and pass the exam first. So when we keep saying that other boards allow this, I don't think we're talking apples and apples. I think we're talking apples and oranges. And I'm reading right from Article 8.315 of the nursing code about temporary licenses. So I think we need to do some more homework because they have to take the test. Again, Scott, we talked at length about solving the problem of testing availability. It's a huge issue, testing availability. That does not mean, I don't believe that we should diminish this very special profession because of testing availability. We need to focus on that problem. And last year was COVID related, and I reluctantly voted for it. I really have a problem with it and will not, but I would be happy to help try to solve the problem in a different way. But I would like to ask the question, you mentioned these other temporary licenses. And again, I just quoted from nurses. Are there any others that allow it without having to pass the test?
Yeah, so, sorry.
Go ahead, I'm sorry.
No, you're totally good. I definitely appreciated the call we had. It was very helpful to fully understand kind of where you're coming from. On the nurses thing, when I'm talking about the nurses, I'm actually citing to 8-301, which does not allow for a temporary licensure per se, but it actually allows for a licensure exemption. So it still allows practice pre-exam. And so if people are interested, that's 301C3, I believe. But that being said, probably the temporary licensure structure that's most similar to what we're looking at here is occupational therapists, and that's 10-313. And that allows for pre-exam practice, again, supervised. The main difference being that there's not even a requirement the exam has to be determined unavailable. It just allows for pre-exam practice under supervision until the supervisee is able to take the exam. So if that one individual isn't able to take it in the first couple months, they could still keep practicing after graduation. So that's probably the one that's the most similar to what we're talking about.
For the sake of time, I'm not going to reiterate our conversation, but I think there's other solutions to this problem. And I thank you for your honesty, and I was honest with you. And I've had a great deal of reluctance with our solution to this problem. And I'm going to have to not support it, but I would like to help you.
I totally understand. I appreciate that.
Let's hear from Delegate Morgan.
Thank you, Madam Chair. My question was for Scott, or if anybody else knows this answer. Just how short are we on social workers throughout the whole state?
It's a great question. We actually have a task force in NASW now that we recently stood up to try to get at this exact question. It's pretty difficult to answer because social workers work in so many different parts of the state, whether that's child protective services or community behavioral health services. They're just all over the place. So it's really hard to tease that out. But, from a lot of employers that we've talked to, almost all of them are understaffed and are sometimes having to bring in non-social workers to do jobs that we probably would rather social workers doing. For example, Baltimore City DHS uses a lot of lay workers who are not social workers because they just don't have enough social workers to provide services. I know a lot of the child welfare social workers aren't a big fan of the reliance on non-social workers to provide DSS services.
Do you know how many new licenses we grant per year now?
I personally do not know. I'm sure Stan definitely knows, but I don't know.
Do you know how many licensed social workers we currently have, like renewing?
I do have that number, but it's not on my notes I prepared for this, but I'm sure Stan knows right off the top of his head.
Dan, why don't you answer the question for Delegate Morgan? How many licensees are we talking about, and new
Sure.
ones as well?
I'd be happy to. We have over 17,000 licensed social workers in the state of Maryland.
Okay.
And the average is actually going up because I think since teletherapy, we've had a lot of people from out of state get licensed in Maryland so that they can practice through teletherapy. And while talking about teletherapy, none of the boards providing teletherapy, psychotherapy permit a temporary license. And they do that because the supervision is very different for social work and these other professions. It's not through direct observation. This is confidential work between a social worker and a client, and it's behind closed doors. So you're always talking about supervision that's removed from the direct observation. And I think this is why psychologists don't have it, and psychiatrists don't have it, and professional counselors don't have it.
Okay,
I appreciate it, Madam Chair.
Absolutely. We're running out of time on this bill. I want to let Delegate Cullison ask her question. And I know Delegate Bandari and Delegate Saab also have questions, but we'll see how long Delegate Cullison's question lasts. I'll try and squeeze you in. If not, it might be next week. Go ahead, Delegate Cullison.
I just wanted to ask if there currently, is there a timeline that people have to take the exam? Or can they graduate in 2022 and decide to take the exam in 2023? And so that's the number one question. And number two question is there a number of times the person can take the exam and not pass it before we say you won't be able to be licensed in Maryland? So those are two pretty concrete questions. Still have strong opinions on the bill, but I'll wait till the next conversation.
Are those questions for Stanley or for Scott, Bonnie?
Stan would know.
Okay. I'd be happy to answer. You can graduate and decide that you'll raise a family and come back and take the exam. So there is no limit that you must take it within a certain period of time. For these licenses, there's a difference for the advanced practice. And the other question was, how many times can you take it? You can take it as many times as you want. And some people take it many times. It's a small percentage, but yes, we have no limit on it. That's their right to be able to come back and take the exam.
Okay. All right. Thank you. Thank you, Madam Chair.
So Delegate Saab and Delegate Bandari, can you write your questions down and we will pick this up next week? Is that okay? Because we have stakeholders here for the other two bills and I don't want them to have wasted an hour of their lives. Yes, excellent. So we will start with Delegate Saab and then Delegate Bandari next week, and we will pick up this conversation. Thank you to everybody. Let's do the dental hygienists for 7 minutes, and that will leave us 7 minutes for the midwives. Dental hygienists. Oh, that's my bill. Right. I'm going to go with Lisa.
Lindsay.
Lindsay, that's what I meant, Lindsay. Go ahead.
This bill is House Bill 219, authorizes a dental hygienist to consult with a patient's registered nurse practitioner, certified nurse midwife, or licensed certified midwife before proceeding with treatment if there is a change in or concerns about a patient's medical history. The bill authorizes a dental hygienist to practice under the general supervision of a licensed dentist in clinical offices of physicians, registered nurse practitioners, certified nurse midwives, or licensed certified midwives. There's an amendment that was circulated on this bill that clarifies that a dental hygienist should consult with the supervising dentist or patient's dentist and the physician, nurse practitioner, certified nurse midwife, or licensed certified midwife, and requires consultation if there's a change in a patient's medical condition in addition to a change in medical history.
Okay, so we were really hoping to get there on this bill and have this bill at the top of the agenda for the easy bills that are all clean and ready to go, but we did not quite get there. So I think there's some disagreement on the impact of the proposed amendment. I want to remind the committee that Delegate Kipke had this bill that we passed out a couple of years ago. We don't want to inadvertently dig into that and sort of roll backwards some of the progress that we made there just for the sake of passing this bill. So that's my concern. But let's hear from Rob and Elliot, I think Caitlin McDonough, and I think Dan Doherty is here, although I don't see him, but I bet he's here somewhere.
Here.
Dan, you are here. Oh, there you are. There's just too many people on my screen. So let's go with Robin first.
So Delegate Kelly, I might suggest that Scott Tiffin take the lead on this one.
Or Scott. I'm sorry. I don't see Scott, but I'm sure he's here somewhere.
I'm still here. Yeah.
Sorry, Scott. I meant to call on you. I talked to Robin about this bill this morning. That's what happened. Go ahead, Scott.
No worries at all. I totally get it. I think you pretty much already covered everything. I think we did appreciate that the dentists had different amendments and they kind of pulled those back and put in these different ones after the hearing. We definitely appreciated them considering that. And we are okay with the small change about initial, getting rid of the word initial in the ones part of the statute. We think that is in the spirit of the original bill. But as you mentioned, we think changing the or to an and about the consult is not really in the spirit of the original bill. And we don't really feel it's necessary. And we think it could be handled in the supervisory agreements that the dentists have to issue. Did want to say one last thing, which is that Robin and I and some of our nurses did meet with the dental board about their concerns, had a very long conversation, and it seems like some of it was a bit just confusion about some of the underlying law that is at play, but we did talk to them as well.
Thank you. Caitlin, you want to add something from the hygienist?
Yeah, and thank you, Delegate Kelly, and thanks to Scott and Dan for working with us on the bill. So I apologize because I think I'm the one who's been a little bit late on this. We've had some leadership changes in the Dental Hygienists Association, so it just took me a little bit to get feedback. So I'll apologize to everyone for that. But we do have a little bit of concerns with the amendment, but because it would require dual consultation in all these circumstances, and even more to the fact, under the original bill, which I think passed in 2019, when we go into physicians' offices now, we do have that option, depending on the circumstances, whether we're consulting with a dentist or with the treating practitioner or the treating physician. And we see that we kind of can make that choice based on whatever the triggering circumstances, meaning if it's a medical issue, it may be something we want to consult with the physician about. More of a dental issue, we go back to the dentist, and nothing precludes us from talking to both. But for every time that there'd be a circumstance that we would have to consult with both, whether it's kind of necessary or not, we think would be a delay in care, and is actually altering our current scope in addition to making some changes to the bill itself. So we'd rather keep it as or. We think that the advanced practice nurses who practice independently, can function similarly to as we function with physicians' offices now. So, happy to work with everybody, but that's kind of where we are right now.
Excellent. Thank you. Dan, let's hear from you.
Thank you, Madam Chair. If I could just expand a little bit on what the bill does. It, for the first time, allows dental hygiene services to be delivered through a nurse practitioner's office or the two classes of nurse midwives offices. And when we had the hearing in the House and the Senate last week, we originally had a dual requirement. It was consultation with the dentist or the physician assistant, but in the case of the nurse midwife, it was and. There was a lot of discussion, and in looking at it, it seems the easiest way to address it is to require the dental hygienist to consult with both, and it only occurs when there's a change in medical health and condition. And that is not, I respectfully submit, going to be a problem because, number one, while they're providing treatment, they must have ability to communicate with the supervising dentist in person, by telephone, or electronically under the current law. So the access to the supervising dentist is clearly provided. And with respect to consulting with the healthcare provider in whose office they are, they're in their office. So they have to have communication set up with the dentist. They are in the office of the healthcare provider. They should be able to communicate with both without any delay.
And the purpose of this is the best interest of the health and safety of the patient. We're talking about what could be some very serious ramifications with health changes. And the more information, the better. And I think the legislation should be directed not to the creme de la creme of each discipline, but to the average practitioner. And we can't trust the average practitioner to necessarily focus immediately on the need for multiple communication. So I think it should be in the statute. Thank you.
Do we have questions from the committee on this right now? I'm not seeing any hands up. Let me double check because there's a lot of people. Okay, so it sounds like the sort of positions are pretty clear to the committee. We're going to pick this up next week, and hopefully we'll, be able to discuss it a little bit more and walk through with the committee sort of what the process currently looks like and what it would look like if we were to add in these new practitioners. So we will continue discussing this in more detail next week. Final bill to discuss for today, let's get a bill number, is House Bill 66, Licensed Direct Entry Midwives Previous Cesarean Section.
This bill allows a licensed direct entry midwife to assume or continue care of a patient if the patient has had a single previous cesarean section that resulted in a confirmed low transverse incision that was performed at least 18 months before the expected date of birth of the current pregnancy. A licensed direct entry midwife must consult with a healthcare practitioner and document the consultation as specified if a client meets these criteria. Before initiating care for a patient with a single previous cesarean section, in addition to obtaining the standard informed consent agreement required under current law, a licensed direct entry midwife must also obtain a signed copy of a state board of nursing approved informed consent agreement that is specific to home birth after a cesarean section. This informed consent agreement must include a description of the procedure, benefits, and risks of home birth after a cesarean section, including conditions that may arise during delivery and any other information that the board requires. I circulated amendments from the sponsor that clarify that if a licensed direct entry midwife is required to consult with a healthcare practitioner because of a patient's single previous cesarean section, that consult must be with an obstetrician, a certified nurse midwife, or a licensed certified midwife. I also draw your attention to the Board of Nursing in their written testimony on this bill suggested that the informed consent should also include alternatives to home birth.
Okay, I'm going to send this to Delegate Cullison, who can give us an update. I don't have my list of stakeholders anymore, so you're going to have to tell us who's here who can update us on this bill. Delegate Cullison.
Thank you, Madam Chair. I think that there's still some work going on behind the scenes here. I believe that the amendment that we brought to you today was addressing one of the issues that we had received prior to the bill, to the hearing. But since then, we've been working to try to find some common ground. I guess just in the total context, before I turn it over to John and to give us a little more information about the work going on, is I think we all appreciate the fact that birth is always going to be a risky situation or has some risk associated with it. But it's always, but clearly we're all here. So it's not a tremendous amount of risk, and we, seem to be repopulating the world. So, we know that there's some risk, and while as a government, we want to minimize the risk. I think, I have not seen the data that says we have increased the risk by allowing licensed direct entry midwives to practice VBACs. And I've seen different, the MHA and MedChi have sent me good information, but it's sometimes comparing apples to oranges. They're not talking about the same procedures or the same timelines. In this bill, we have set up really rigid requirements around when it can happen. The woman and her family are making an informed decision based on complete information. So with that, that's why I continue to be supportive of this bill. And John, do you want to add anything? John, are you there?
I don't know.
Okay, I guess Caitlin.
Okay. Okay.
It's wrong person. Sorry.
Oh, no. And I was like, okay. No, thank you, Delegate Collison. Thank you, Delegate Kelly. I think you summed it up pretty well. Just for the record, on behalf of the Association of Independent Midwives of Maryland and Maryland Families for Safe Birth, we're fine. We're pleased to accept the amendment, kind of clarifying the consultation with maternal health practitioners who this is already within their scope and would have experience in this space, and also the Board of Nursing. We want to be as clear in the informed consent for VBAC, about all of the information, risks and possibilities and alternatives as possible. So, we welcome those amendments. I know that there is outstanding concerns with the bill, but, similar to what Delegate Bagnall said, we may have come as far as we can to making this as safe as possible without substantially limiting access to care. And that's pretty much where we are. So we appreciate the committee's time.
Excellent. We've got like a minute and a half left. So let's see, do we want to hear from Pam or someone from the Hospital Association? Does anybody else feel the need to weigh in right now on this, where we're at? Wow. Okay. Go ahead.
I will real shortly. Want to say up front to the sponsor, I wish we'd gotten you some additional language a little bit sooner than we did, but we do have some additional changes. We don't think they're absolute barriers. We appreciate the sponsors working with us. We aren't going to move off our position that we think that VBAC at home is extraordinarily different and a different risk level than everything else. That being said, we're very appreciative of her and the advocates working with us to figure out if we can get a framework. I don't think we'll ever like it, but at least where we feel like we've got the safety provisions as strong as possible without undermining the intent of the sponsor and the advocates.
And Madam Chair, if I might, I just want to thank Pam and ACOG and MHA for continuing to work with us on this and get to maybe not consensus, but at least resolution, perhaps.
Excellent. So we will pick up this conversation in subsequent weeks, and I thank all of the stakeholders for your work on this. I don't see any hands up from any members right now because they're so respectful of the clock. I really appreciate the work of the subcommittee today. All the bills that we did not move out today, we will pick up again next week. Keep your ears open because it seems as though our regular subcommittee meeting time may not work next week, so we might have to move to Wednesday or Friday. So stay tuned for that, but we will be meeting next week on these bills as well as some new bills. So with that, thank you so much to everybody for your hard work today. Meeting adjourned.